Today we have Dr. Elizabeth Poynor with us, and this is really Menopause 101.
Perimenopause is an opportunity, I think. It will get you to the gym. It will get you to pay attention to your nutrition.
We are going to get granular and very specific about HRT and how that can help you through the spectrum of menopause. And we're going to get very specific on what's happening to your body during menopause, why you need to be thinking about HRT.
So there was a big cardiac protection benefit of 30% risk of cardiac disease in the hormone support arm.
We're going to go through everything from the weight gain to sleep to moods, all kinds of things. So please stay tuned. You are really going to get all of the information that you need in this episode. Welcome to the Embrace Live podcast, a masterclass in living well, where we uncover how New York's most successful leaders in business, media, and entertainment navigate the intensity of this city while prioritizing wellness, health, purpose, and fulfillment. From boardrooms to red carpets, we dive deep into the habits, mindset, and resilience that keep them thriving in the city that never sleeps. Okay, today we have an incredible guest. I've taken lots of notes for this interview because the subject matter, I think, is going to be valuable to everybody listening. We have Dr. Elizabeth Poynor, who is a trailblazer in women's health and one of the most sought-after experts in hormone health and gynecological oncology. Dr. Poynor's distinguished career has made her a trusted advisor to many women. Some of those women are my clients. She has been on Martha Stewart's podcast, and Martha Stewart is also one of her clients. She has most recently written an article in Time magazine. And so we are going to have a lot of insight, a lot of fun, but today is really about getting deep into what's happening with women's health as it pertains to menopause. Dr. Poynor?
Thank you. Thank you for that great introduction. Thanks for allowing me to chat with you today.
Oh, anytime. It's a pleasure to have you. Did I miss anything in that introduction?
You know, I don't think so. I'm just honored to be here. Get to talk about my favorite topic.
Brilliant. Well, listen, I'm glad it is your favorite topic, and especially the amount of research that you've done, the amount of work you've done in this area. I mean, your career has been prolific, and we'll talk about that in a second. But my goal today is to accomplish a few things, right? I think that, and that's why I've got all these notes today, is that we want to take like a really broad, high view of how menopause is viewed, hormone replacement therapy, some of the misconceptions around that. And then with the amount of questions that I get, I want to be able to drill down on some real specifics, some real things that are either actionable or that are going to help our female audience really understand, what they can do during this stage of life. So let's start by talking a little bit. I know you had a thriving practice and you left that practice to do some really cutting edge work right now. Can you tell us a little bit about what that is?
So I'm working as chair of women's health for Atria Institute and Atria Health, and we are trying to change the paradigm of medicine from shifting to reactive sick care to proactive health care, basically. Mm-hmm. And so women's health has really suffered from this reaction to an illness or to a problem and not been proactive. So I jumped ship from my private practice and closed it. I felt like I was ripping my heart out of my chest 100 times over and miss everybody desperately, but felt the need to be around real experts and leaders in brain health, neurologic health, cardiac health, metabolic health, endocrinology, naturopathy, PT, exercise, nutrition. We kind of have everybody under one roof. And then we really want to take all the different systems. And my job is to really string the thread through women's health, through all of these different systems, to look at how women's physiology changes as we age, not only with our reproductive organs, but also our brain health, our cardiac health, our metabolic health. So we're really doing a deep dive into women's health and connecting the dots through all the systems, because every organ system is affected by estrogen fluctuations and hormone fluctuations. We have estrogen receptors all through our body, and we really need to look at women's health through that hormonal lens, but also far beyond just reproductive health, but also all of the organ systems, basically.
Fantastic. And there's an AI element to this. Is that correct? There's a technology element?
There's a large technology element and a large push, because we're amassing massive amounts of data and information, and we want to find out what is most useful and how can we use it and how can we intervene to improve the health of everybody, basically, and to move into that proactive stance and react to, and not react to something after there's a problem, but to catch it either as the problem is evolving or just to prevent the problem altogether.
And that's really why I'm excited to have you on today, because there's obviously your career in working with women, working with menopause, but also you're really on the edge of what's happening in the future, right? And so I think marrying those two things is going to give us as much up-to-date information as we possibly can, right?
Totally correct. And, and you can even look at, I look at my career trajectory, and I was a cancer surgeon, really only doing ovarian cancer work for 16 years. And really the new medicine and is to really look at preventative medicine and preventative strategies. And that's our new frontier. We're at a renaissance in cancer therapies and cancer treatments, and we're doing really, really well with them. We can always do much better, obviously, and we have got great scientists, but we need to have great scientists and great people involved in preventative medicine also. And in the past, the super subspecialists were the people who were the scientists, and they were the people who were on the cutting edge. We also need to take primary care and make that on the cutting edge also. That's our new medicine, in addition to our super subspecialized medicine.
And to that point, we talk about preventive care, and we've heard about it for many years, but moving that to the forefront, that's a huge shift, right?
Totally.
So how, in your opinion, is that going to happen in reality? Because the whole system is not set up for that, right?
We can't deconstruct the system, right? We have to work around the system, and we have to develop a new system, because to deconstruct a system takes time to deconstruct it, and then you have all the negativity of that. But we have to do workarounds, and we have to go, my grandmother always said, you have to go around the rose bush so you avoid the thorns, right? You can't go right through the thorns of the system, right? So we have to develop a new system, and that's what we're working on right now. How do we develop that new system? And then how will that integrate and interplay with the system that we have right now? Because our system right now has given us cancer cures, given us cures for many illnesses, have given us transplant technology that's beyond science fiction from the from the 1980s, what anybody could imagine, right? So we need to hold on to that. We can't deconstruct that, but then we have to also, in addition, have this primary preventative medicine, and that's going to require developing a new system in terms of that integrates with our current system.
Right. Fantastic. Now, again, before we get into this, now my clientele, typically women 40 plus, right? Some who have started menopause, some who are going through menopause, and they are some of the most, educated, on the cutting edge, understand what's happening with the times, right? And, we've figured a few things out with the training part of it and the nutrition part of it, and they get these incredible results. But one of the frustrations I'm always hearing, and there's more to the picture than just this, but is they'll get to a stage in their life and they're like, what I'm doing is not working anymore. I'm eating the same things. I'm working out twice as hard. I'm adding all of these different things to my life. And yet, I find that my waistline is getting a little, is increasing. I find that my energy is decreasing. I'm starting to get brain fog, right? And even with this most enlightened clientele, they'll ask me, do you think I'm in pre? Do you think I'm in peri? Do you think I'm going through menopause? And I'm like, well, if you don't know, I'm not equipped to tell you that, right? So I guess my question is, how does this kind of thing show up how did it show up in your practice?
So, well, it showed up in my practice two ways. One, I actually went through menopause when I was 43. So I went through perimenopause at 43, and I was running this, hugely busy surgical oncology practice doing very large operations. And all of a sudden I got a little anxiety, and it was a little depression, a little anxiety. And I was like, I'm not a depressed individual, and I'm certainly not an anxious individual. I was like, well, nobody wants an anxiety-ridden, depressed cancer surgeon, right? So I had to figure it out. And I spoke to my mom a little bit, oddly, who is not a physician. physician, but who had, gone through menopause, and spoke to her a little bit, went to the medical literature, went to the psychiatric literature going, why would I have this new onset of this little bit of mood swings? And really it was my mom who actually is in a technology industry who said, I think it's probably your estrogen. And so she goes, just use one of these patches and see how you do. So I prescribed myself a patch and I instantaneously felt better.
Okay, so hold on. I have to stop you right there. So you're running a practice.
Yes.
And your practice is focused on what at this time?
It's really focused on cancer surgery and complex gynecology at the time.
Okay. And gynecology, right? So you're dealing with women all the time, right? And so you had this career, you're running this office.
Yeah.
And the advice that you have to get when you're going through this is from your mom.
Correct. Correct. Right. So, and I have like all the best education behind me, right? I mean, and I'm not stupid, and I was listening in class, but there's no education. I mean, this is like, this highlights that there's no education on midlife women's health. There's no education on menopause. Still to this day in our training programs, people get about, 1 or 2 hours of didactic sessions or lectures, basically.
1 or 2 hours.
And this is when women go through a very large physiologic shift that they'll live with for their lifetime. I mean, as women, we also normalize things too. We have monthly cycles where we have pain, we are bloated, we don't feel so great. It's normal. It's your period, right? We go through childbirth. It's painful. It's normal. It's childbirth. We tend to normalize a lot in women's health. And I think the reason why this didn't have as much attention paid to it in the past is we normalize a lot of quality of life problems. But in addition to the quality of life issues, there's also real physiologic changes that have real medical implications, because just as like you're shape shifting, I call it shape shifting, right? Everybody has this, basically, you get a little thicker, right? And that usually happens maybe about 5 years before menopause, even before we even realize that there's a hormonal shift, right? Or we'll see some shape shifting. But with that comes real physiologic changes. Your lipids may go into a more adverse lipid profile. Your cardiac disease risk starts to go up a little bit. Plaque may be beginning to develop. So even before we have the final menstrual period, which is menopause, we have all of these other indicators that something is changing in our physiology. And we have to listen to those indicators. So I became a listener, actually. After I went through this experience, I became a listener, and I just listened to my patients. And my patients taught me. I didn't learn this in medical school. I didn't learn it in residency. I didn't learn it in fellowship. I learned it from my patients by just listening to their narratives. And you could hear people saying, my waist is getting a little bit thicker, I'm gaining weight. And we have this data in the literature that women gain between 5 and 7 pounds in the menopausal transition. We have metabolic disruption. We become more insulin resistant. We have more metabolic brittle, more brittle. So there's a lot of things that are happening.
Right. Now we're going to talk about this in a little bit, but can you break down metabolic disruption, insulin resistance? Like, what does that mean on a very basic level?
That means that we basically don't have enough insulin to deal with our glucose spikes. So our glucose stays in our blood, and it doesn't get used up by our cells the way it's supposed to get used up. And so then it causes metabolic disruption, where we become basically in an inflamed state. So so lower levels of estrogen lead to higher levels of inflammation. That leads to more visceral fat deposition. So that's the shape shifting, right? We're putting on visceral fat, right? The fat may move from our hips and our thighs into our waist at this point. And so it comes from the fact that we can't use and utilize our glucose the same way. And that's called insulin resistance. Okay,
fantastic. Now, one last thing before we really jump in. So I read somewhere that as you're going through this on your personal journey now, your husband is also a surgeon, right?
Right.
Okay. And so there's always that conversation between, spouses. I'm going to take this, or I'm thinking about doing this. What was your husband's reaction?
So my husband is a melanoma surgeon. He's also a breast surgeon. So he deals with many women, actually, and many women who may be taken off of estrogen if they're using it, or maybe putting on estrogen inhibitors with a history of breast cancer. And his reaction was, wow, this isn't for sissies. This is real stuff. He was shocked at how real the changes become, actually. And because he hadn't learned them, and he's got a great resume, got great education, and he's a great surgeon, but never taught these changes. And so he always says that we need to write a book for men also, or for partners, male and men, for partners basically, and how, what these changes are. And so he had actually said to me at one point, he goes, no wife of mine is going to take estrogen. And I was
Right.
like, I'm taking estrogen because I'm my own person, right?
Right.
And now he kind of chases after me with the estrogen. If I forget it, he's like, did you remember to pack your estrogen? So he's had his own education
Right.
through the work that we've done in the practice, but also at a personal level. And we really do need to have a broad education of everybody,
Right.
so people can understand. And even in the workplace, we know that women who, and your clientele especially too, who are in the workplace may have issues with kind of menopausal changes, whether it's mood changes, energy changes. But now there's a big push for menopause in the workplace so that individuals who are employers can also understand what women are going through.
And it's just crazy to me that, with both of you are like high-level doctors, you're surgeons, right? And so even at that point, at that level of education, that certain information wasn't there at a certain point, right?
Right,
and so
correct.
for the average person, how much further are we from getting, the necessary information and perspective?
I think it's perspective. The information is there. If it's all in the literature, this is what has really that has really impressed me recently over the past few years. When we're working on a book right now. Obviously, I'm doing a lot of research where I am right now, and the research is all there. A lot of it's there. Much of it's there. It's just really well siloed. You have to read across specialties. So for me to understand about brain health, what happens with fluctuating levels of estrogen, I have to go to the neurologic literature.
Got you.
For cardiac health, I've got to go to cardiac literature. So you have to be super curious to connect the dots. And so I think it's the perspective of connecting the dots. And we need to develop a specialty where we connect the dots for women. And we have people that can read across different subspecialties and put this story together for women. So I think it's more about perspective. Certainly, there's a ton of work that needs to be done. But before we do that ton of work, we need a great foundation where we look at everything as a whole and then figure out what the next step should be.
Okay, fantastic. Now, we're just going to get granular and very simple, right? What is menopause?
Menopause is the final menstrual period, basically. So postmenopause is 12 months after your final menstrual period. Menopause is right after your final menstrual period. The years immediately after you're trying to figure out, is that my last menstrual period, are called perimenopause. That may go on to 2 to 3 years after, kind of, But for 1 year solid, if you haven't had a period, you're postmenopausal. So menopause is that final menstrual period. Perimenopause is anywhere between up to 10, maybe 12 years, even before your final menstrual period. It's where estrogen levels are beginning to fluctuate. And there's something called the late reproductive years, are where estrogen levels are starting to change a little bit, which may be 35 on. Perimenopause is the time leading up to the final menstrual period. While you're trying to figure out whether that's the final menstrual period or not, that's
Right.
still perimenopause. When you 12 months after that
Right.
final menstrual period, you're postmenopausal.
Okay. And so when would perimenopause start?
So that's a great question, because how do we measure perimenopause? Like a lot of things in medicine can we measure it?
Right.
And if we can't measure it, it must not be there, right?
Right.
But that's really, this is more done, diagnostic is done more through a narrative. So perimenopause starts, there's the early perimenopausal transition, which is well defined by studies that were done in the early 2000s, where you may start having some menstrual irregularity, right? You may have that shape shifting, you may have a little bit of brain fog, you may have some libido issues, a little bit of vaginal dryness. But really, the studies have looked at, okay, you have to have some change in your menstrual pattern to be in that early perimenopausal transition. Those changes are probably happening even before that. Those are the late reproductive years.
Gotcha.
So perimenopause kind of starts when you start to have these symptoms with menstrual irregularities. And then the late perimenopausal transition is when we start to see abnormalities in the pituitary hormones, FSH and LH. So then we can start to measure things in a laboratory and say, oh, your FSH is elevated. Prior to this, if you check hormone levels and they're random hormone levels, they're all going to be normal. You can do some more sophisticated and more integrative hormone testing called Dutch testing, which is a dried urine testing, which I love. It's a cycle mapping, and I can
Right.
see, because we know that there's 4 different types of perimenopause. Everybody's progesterone level goes down in perimenopause, but estrogen levels may taper down, they may crash down, and we can measure that with Dutch testing.
You said there's 4 different types of perimenopause.
Right.
Did I get that correct?
Correct.
Okay, what are those 4 different types?
So they don't have a defined name, but you can see on the estrogen curves, some people will have just a trend where their estrogen level is just slowly dropping.
Mhm.
Some people will have a trend where their estrogen level is going up and down, but slowly dropping. Some people will have a spike in their estrogen level, and then it will start to go down. And then there's iterations in between that, right? So some women will have these very erratic high estrogen levels. And I always hear people saying, well, you're fine. You're not in perimenopause because your estrogen level is high. Yeah, but like 3 days from that, it could be like, down to like less than 15 or
Right.
like very, very low. So we have to look at these patterns of change of estrogen over time,
Right.
basically. And that's what these studies in the early 2000s did, actually.
So now, if you're not getting tested,
Right.
right, how do you
To listen.
just, and what does listening look like?
So listening means educating healthcare providers to what to listen to and for, right? Prompting individuals to speak to us about certain symptoms, because sometimes people won't talk to you have to pull things out of people, right? You have to ask the question, right? So we have to understand what the questions are that we are asking. So this is on the provider side. We have to come up and educate our providers and say, okay, these are the symptoms of early perimenopause and that you need to be aware of, that women may be experiencing some mood issues. But at the same time, we need to educate individuals who are going through actually perimenopause. Like, these are the things that you need to bring to your doctor. And I think that this is a big push in technology, that if we can get those questions to both the healthcare providers and the individuals who are going through perimenopause so that they can talk to each other but a lot of people don't even know what those questions are. I mean, the whole, you still hear on the street like, oh, you're gaining weight. Oh, it's just your age. Well, no, it's your estrogen levels. It may be a little bit of your age, but a lot of it's your estrogen levels.
So if there's like 4 things that the audience can look out for when they're going through, to be able to think, maybe I need to listen to that, or maybe, all right, maybe something's happening here. What would they be?
I think so I always say that we paint our lives on a canvas that goes from bright white to dark black, right? And shades of gray in between, right? In terms of our attitude and the sunniness of our life, right? And hormones don't necessarily change that, but they shift it, right? They may make you a little bit, little moodier, a little bit more upset, or something that wouldn't upset you in the past actually now upsets you now, and you're not reacting to it in the same way. So kind of subtle mood shifting, brain fog, shape shifting, but know your body, listen to your body. The most important thing that I can tell individuals is know your body. If something's different, figure out why it's different. If you're not getting an answer from one provider, get somebody else to get engaged with, because, but knowing your body and listening to your body. And if something seems not right to you, get to your provider. But really, it's some of the earliest changes, I think, are subtle mood changes. Like, I also call it like loss of joie de vivre, right? Like, you just don't feel the same. Loss of self-confidence. A lot of women, when they're going through perimenopause and menopause, don't have the same self-confidence when you're in a room. And if you look at a lot of the behaviors associated with menopause, they're almost a little antisocial. Like, you kind of just want to be by yourself and you don't want to go out. But that along with some subtle hot flashes, temperature changes, although many women won't have those until later in the transition, shape shifting, libido issues are an early kind of change that we see in terms of a little bit of a lower libido, and you can't really explain why. And then vaginal dryness in the second half of the cycle. I hear over and over, I've got a little bit more vaginal dryness. And then we correlate that with some Dutch cycle mapping, and we see that, the estrogen levels are beginning to drop. Okay.
And are there any procedures, operations that can accelerate how fast you go into menopause?
Well, of course, if you've had your ovaries removed, right? And this is another reason why I got very largely involved in this world too, is that, I was doing oophorectomies for young women who are at genetic risk for ovarian cancer and, suffering with quality of life issues. And now we know that women who have their ovaries out earlier have a higher risk of dementia if they don't go on hormone support. So, of course, if you've had your ovaries removed, if you've had, of course, radiation to the pelvis or radiation that may hit the pelvis, that can cause ovarian dysfunction. Some chemotherapies can cause ovarian dysfunction, not all of them. And then hysterectomy may be associated with an earlier menopause. And that's a tricky one because now you don't have menstrual irregularities to go by. You have to go by purely narrative until those later transitions.
Right. Wow. I mean, even in there's so many little variations.
There's right. And and you can see like this giant algorithm of how to begin to interpret, okay, the narrative with the labs, with the history.
Right.
And that's where AI can be super, super helpful. That's where our technology can be really helpful to make everybody, every provider, a women's health expert, to make every woman or an individual who's going through this their own expert too, so that they can take that to their provider also.
Fantastic. So now, HRT, hormone replacement therapy, has gotten a bad rap for many, many years. I think it was the Women's Health Initiative study.
Correct.
Can you give us like a high-level view of what happened, how we got here? I mean, because even for me, I've been researching this just because of who my clientele are. And I'll mention it and people will balk, or people, I mean, I say testosterone and it's like, you're trying to turn me into a man. What is happening here?
Yeah.
So how do we, give us the high level view of what happened and how we got here in terms of people's view of HRT?
So I always say the advantage of talking to somebody really old or having an old doctor is you've seen it all. So I've lived through this whole history, right?
Right.
So prior to the Women's Health Initiative study, we would take out ovaries, or we would have women who went through menopause and we'd say, here, take this prescription of Premarin or Prempro, right? It's going to protect your heart. So we all thought that HRT was cardioprotective. And then there was a study that was ongoing, and it was published in early 2000s, the Women's Health Initiative study. And it took many women between the ages of 50 and 79, and it randomized them to Prempro or placebo, or Premarin alone, or placebo if they didn't have a uterus. So Premarin is an estrogen. It was the popular estrogen at the time from pregnant mare's urine. And then the Provera is a synthetic progestin. And both of these are really important because the Premarin is an oral medication that we don't use anymore. So we have safer transdermal or skin preparations that we use.
Okay.
And Provera is a synthetic medication that we also don't use very much anymore. We use a natural progesterone now. So natural progesterone we now know is much safer than Provera, and transdermal estrogens are much safer than oral estrogens. So there was unexpected results from the Women's Health Initiative study, and they found that there was a higher risk of stroke, DVT, pulmonary embolus, so blood clots with the Prempro. They also found that there was an elevated risk of, the investigators found that there's an elevated risk of breast cancer by 25%. So your breast cancer risk went up by 1.25 times if you were using Prempro over placebo. That was enough for the investigators to shut down the study, but also, really importantly, that was enough to splash across the headlines, all through the New York Times, all through the headlines everywhere, every major publication. Estrogen causes breast cancer, like hormone support causes breast cancer, and that shut down. I mean, we wrote letters. I was at Sloan Kettering at the time, and we wrote letters saying, stop your estrogen immediately. It causes breast cancer, and so everybody was taking off their estrogen. Well, at the same time, the French were doing, at the similar time, the E3N study. The difference between the E3N study and the Women's Health Initiative, couplefold, but one, they were using natural progesterone because the French had natural progesterone in 1990. We didn't have it until 1998 in this country. And it was also what we call an observational study. So as we were just looking at a group of women and did they develop cancer, yes or no, and did they have protection of cardiac disease? But what the E3N study showed is that natural progesterone doesn't increase your risk of breast cancer. But importantly, what the Women's Health Initiative study also showed is that when you stratified the study between women who were between the ages of 50 and 60, took out those women who were between the ages of 60 and 79, there was a big cardioprotective benefit. So when we did subset analysis, so there was a big cardiac protection benefit of 30% risk of cardiac disease, 30 to 40% risk of reduction of death from all causes in the hormone support arm. So what this told us is, one, don't jump to conclusions when you first look at a study, and also that you have to, there's a window of opportunity for hormone support, before the age of 60 or within 10 years of menopause. And this is the well-accepted kind of, I call it the sweet spot, right, of when we can prescribe hormone support and get some really great physiologic benefit from it. But people still hold on to this risk of breast cancer, and that estrogens cause breast cancer, and they don't. Estrogen alone in the Women's Health Initiative study did not lead to an elevated risk of breast cancer. Estrogen plus natural progesterone does not increase your risk of breast cancer, but estrogen plus this old-fashioned drug called Provera increases your risk of breast cancer. But unless you're super curious and you're reading all the literature and you're super proactive, you hold on to that old Women's Health Initiative study, which we can't do. We have to move past it.
Wow. So just to clarify, so estrogen plus the progesterone, natural progesterone that is widely used and widely available now does not cause breast cancer.
Correct. In these studies, in these observations, they're observational studies, they're not randomized. In observational studies, the relative risk of breast cancer with natural progesterone plus estrogen is 1. So no elevated risk.
Wow. Okay. And what about cardiovascular?
Cardiovascular protection, 30 to 40% reduction in cardiac disease if instituted early. It's not going to treat cardiac disease that's already set up, but it will prevent cardiac disease.
And that's estrogen, progesterone combination will help prevent.
Correct. Estrogen alone or estrogen plus progesterone will help prevent cardiac disease.
Okay.
Which is the leading cause of death in women.
That's crazy.
It's
crazy that
stories will be written about this, I think, about why our medical community has held on so strongly. And it's loosening up a little bit now, but still our indications are really to treat symptoms, right? If you look at the FDA indications for estrogen, it's hot flashes, vaginal dryness, prevention of bone disease, basically. But now we're loosening up and saying, okay, well now, brain fog, mood issues, some of these other issues. But we, really the policymakers really need to reassess where we are with this. We really need to assess putting estrogen up front. And I think that conversation is beginning. It's just beginning. People are really beginning to converse about it. We need real academics involved in that conversation. I mean, we really need great data analysis and we need great minds to think about this, but we need to have this conversation. It's time for this conversation.
So again, now I can be hyperbolic, but it just seems like, because when was that study done?
It was published in 2002.
So we're now 2023, right? So almost quarter of a century, right? And for quarter of a century, there has been this solution that many women could have had treatment by or engaged in that has been, I don't want to say denied, but has been missing, right?
Correct.
And so that has had to have had an impact on many women's lives.
Correct. And not only has it's been something that's been missing, but also along with that, what's been missing is okay, there's real metabolic disruption here. We need to really look at, how do we counsel women on nutrition? There's really loss of bone, muscle mass here. There's loss of bone mass. We really need to counsel women, right? We need to figure out what we can do. If we're not talking about estrogen, something else that we can do. We basically passively have just ignored basically midlife women's health.
Wow. Which is...
And it's huge physiologic changes, right? Huge and well-defined. And as I said, it's in the literature. This stuff is all there. And, well-defined, but yet we need to put the story together for women, basically.
Because, we can talk about it as statistics, but that's aunties, sisters, mothers, that's you know what I mean? That's real lives, right? Now, I guess... Before we jump in, we're going to go very specifically through a few things. So it might get redundant, but I really want to go step by step. But before we do that, can we talk about testosterone?
Oh, I love to talk about testosterone. Yes. Super important hormone for women, right? Not well studied. Better studied in Australia and the United Kingdom. Australia is the only country that has testosterone on formulary. So you can go to a pharmacy and get it for women. Actually, UK, you can get it under some coverage from Australia. In this country, if you're a woman who wants to use testosterone, you either have to use men's testosterone and try to figure out how to dose it, or you go to a compounding pharmacy. But molecule per molecule, we have more testosterone, women have more testosterone in their bodies than estrogen, actually. And we know there's a lot of data that shows that mood issues are related to, or can be improved with testosterone, and related to testosterone. We have that from the sexual health data in testosterone. But it's emerging that testosterone is probably really important for many other aspects of physiologic functioning. A lot of that A lot of that study, though, is going on in Australia, actually. There's a large study going on now looking at testosterone and cardiac disease and cardiac functionality. In this country, though, we had testosterone to go through the FDA under sexual health disorders, right? So women with low libidos, did testosterone help, yes or no? It helped some women, didn't help enough, though, for the FDA to approve it. And, women's sexual response is super complex. So there's psychological issues, there's physiologic issues. So there may be a great subset of women whose lives are improved with testosterone now, many individuals categorically deny testosterone to women because it's not FDA approved. So super important, really needs to be studied, important for not only libido, but also maintenance of muscle mass, maybe even cognitive health, maybe better cardiac function. And we really need to get that data. And there's a couple of studies, there's like 2 studies going on in the world right now with testosterone.
Wow.
It's like not that many. And again, we need to push that agenda forward.
Now, I had heard that it was preventative for some cancers. Is that correct or not really?
I wouldn't. There's some data in the literature that shows that testosterone actually can positively impact breast cancer, actually breast cancer cells, actually. Some of that data is done though. So the problem with using testosterone after breast cancer, which some people do, but you have to be super careful about it, is some of the testosterone is converted to estrogen in a woman's body. And estrogen is like, it's like a fertilizer, right? If you don't have cancer, it doesn't make it grow. But if you have cancer, it can make it grow. So some of that study with testosterone and breast cancer actually comes out of using testosterone with something called an aromatase inhibitor so that it's not converted into estrogen.
Gotcha.
But there's a little bit of data in the literature to show that testosterone may positively impact breast cancer, just testosterone on breast cancer cells, meaning it can halt the growth. But that's sparse literature.
Help or halt?
Halt the growth. So, but it's sparse literature. Wouldn't hang my hat on it too much, but demonstrates that we really need the good safety data and how we dose it and how we prepare it, how we dose it. But that can make you feel a little bit more comfortable when you're using it, basically.
Okay, so we're going to go through the effects of menopause and hormones in these different areas. And then we're going to circle back and talk about how specific HRT treatments can help, right? So, body fat. How does menopause affect body fat?
So there's shape-shifting with body fat, right? So we tend to put on that visceral fat and that inflammatory related fat, right? And so hormone therapies don't reverse what's already done. So this is one of the things I'm really interested in. You want to get it on board before these switches flip that you can't undo. So it will halt additional body visceral fat accumulation, but it becomes very difficult to get rid of what's already there. And we know from some animal data, right, that giving estrogen will help with metabolism, right? We have that from animal data. We have that from human data. There's a group that Zoe, which showed that there's less insulin resistance if you're taking estrogen. But we also know from some animal studies that once there's some damage done to the pancreas, which makes insulin with lower levels of estrogen, you can't unflip that switch. So the idea is if you start feeling something a little unusual, some shape shifting, can't lose that weight the same way, you should talk to somebody, I think, who has a very deep interest in this field and talk to them about maybe it's time. And this is a little radical about talking about hormone support, right? Because you definitely want to get it before some of these switches flip.
Right. And about what age would that be?
It can be it can be as early as 35 for some women, right? Early menopause is less than 40. So some people will go through shifts at 35 or premature ovarian insufficiency less than 40. Early menopause is 45. So if you think that 10 years before you go through menopause, if a younger side of menopause is 45, it can be as early as 35. But definitely like mid 40s is when you will really hear about shape shifting. And that's when you really have to say, is it time to get a little estrogen on board?
Right.
And these are like some of these newer conversations that we have to have in terms of moving things up front. Don't be reactionary. Don't wait till you haven't had a period and you're drenched in hot flashes and you've gained 10 pounds. Try to catch it beforehand. Be proactive.
Okay. Lean muscle mass. Easy.
Yeah, that goes down. Yeah, that goes down with androgens and estrogen, right? So strength training, right? And definitely there's some data that testosterone will help build, lean muscle mass also.
Okay, brain fog. Brain function, I should say.
Oh, brain function. That's actually one of the things that I'm so interested in. So definitely there's brain fog that occurs around the time of perimenopause when you start to have fluctuating estrogen levels. We definitely see changes in the brain. Mosconi and her group at Cornell and a number of other people have done work that have shown that the mitochondria, or the energy powerhouses in the brain, change as estrogen levels start to decline. Perfusion of the brain changes. Plaques and tangles start to set up when estrogen levels are lower.
What's perfusion of the brain?
Blood flow to the brain.
Right.
Yeah. And then metabolism in the brain changes. We're not as good at using glucose in the brain when our estrogen levels are lower. So we still see real changes with like lower levels of estrogen equal real changes in the brain. And we know that women have a twofold incidence of developing dementia, right? So they have 2 times the chance of developing dementia when compared to a man. And 2/3 of dementia patients are actually women. So women have some extra risk of dementia when compared to men. And the question is if we give hormone support, can that decrease our risk of developing dementia? And there's a lot of data in the literature that shows that if you can hit somebody within 1 to 3 years of menopause with estrogen, right, that you can decrease the risk of dementia. We need more data. We need to have more people to look at this. We need to look at biomarker data in terms of before and after estrogen, because this would really impact women's lives if we can, prevent dementia and get an estrogen on board, if that really works. And Lisa Mosconi and her group at Cornell have also shown that when estrogen levels go down, the number of estrogen receptors in the brain go up, meaning the brain is hungry for estrogen, she says, right? So there's some real action that goes on. Brain fog, which is, fuzzy thinking, basically maybe some memory issues, maybe some word finding difficulty, maybe not having the same self-confidence in your conversations, kind of gets better as you transition through menopause for some people. For some people, it doesn't get better. For many, it does get better. But is that physiologic damage already done that puts you at elevated risk for developing dementia in the future? And these are areas of active research that we really need to get going and get moving on.
Wow. I just think it's so interesting that there's this profound shift in what's happening.
Oh,
I mean,
whole physiology changes, whole body changes.
Yeah.
It's like every organ system where there's estrogen receptors, which is throughout the body, right? And yeah, everything changes. That's why we need to have people across subspecialties involved who are actively interested in, what is estrogen's influence on and fill in the blank, right? And interestingly, if you PubMed this, right, people are like, oh, there's no research on menopause and this and menopause and that. You don't Google or you don't put into PubMed menopause, you put in estrogen or fluctuating estrogen and then get this. So there's data, it's just siloed. We have to put it together.
Metabolism.
Yeah. So that's the insulin resistance, right? That's linked to shape-shifting weight gain, increase in visceral adiposity or visceral fat. And again, that's just, that becomes a self-fulfilling prophecy. Like the more visceral fat you deposit, the more inflammation you get, the more. And so it just becomes this inflammatory cascade of just increasing waistline, basically. And so you have to put the stop to that through lifestyle, nutrition, sleep, exercise, hormone support. And it requires a multifaceted approach.
Skin and bones.
Skin collagen decreases, and we lose elasticity, more fine lines and wrinkles. There's a big move to estrogen creams for the face. Everybody's like, it's like magic. I'm like, yeah, it's like there's like the skin responds to estrogen, right?
Oh, it works.
Yes, it does work. And there's data in the literature that shows that it works. It increases collagen. So definitely, there's definitely skin changes, and your skin may become a little bit more dry. And so there's definitely some products on the market now, that are directed at drier skin. Bones, we've known about for a long time that bone health takes a real hit, that as estrogen levels go down, you start to lose bone. What, though, is interesting is you start to lose bone like 3 years before the final menstrual period. It doesn't start with the final menstrual period. So we need to talk about doing bone density sooner rather than later so that we can see the at-risk women. So it goes down a few years before menopause and then continues after the final menstrual period.
The thing that I'm getting from all of this is that, many times we say, oh, it's age, you're aging.
Totally,
you're aging.
Yeah.
It's not that you're aging, it's that your estrogen levels are going down or your progesterone is going down, and there are some solutions for that.
Totally. Yeah. And there are solutions, people like yourself with, with great training and nutrition. I mean, and we need everybody engaged. We need kind of every subspecialty engaged. We need, lifestyle people engaged. We need exercise is so important. Strength training is so important. But there are things that you can do. I mean, it's that your ovaries aged, right? Your ovaries aged, and there's people, it's ovarian aging, right? Because it's when those follicles aren't there anymore and we don't ovulate that we don't produce estrogen anymore. So there's people now looking at ovarian aging and how can we, reverse ovarian aging, or how can we at least prevent the decline, the steady decline from ovarian aging, which starts like when we're 20 weeks in utero, by the way. 20 weeks in utero, we have like tons of oocytes or follicles. And then when we're born, we're down many by the time we're born. So it's like
oh, man,
we're screwed. We're screwed from the beginning. Like we're screwed at the very beginning. So there's people who are really working with, drugs like rapamycin or other techniques or PRP to try to halt ovarian aging.
Wow.
Yeah.
Emotions, mood.
Yeah. Anxiety can crop up for the first time. Depression, it's more anxiety, a little more irritability, right? Depression can settle in. Some women will say, I've been on this Lexapro for years and it's just not working for me anymore. And the psychiatrist will start to change around medications. And many times it's like add a little bit of estrogen, you'll feel a little bit better. A little bit of progesterone, you'll feel a little bit better. So we just have to remember that if somebody's changing and they're around midlife and they have 2 X chromosomes, that we have to always consider that there's estrogen fluctuations, but definitely anxiety and depression can get a little bit worse. And they can occur early on in perimenopause.
And then a big one is sleep. Because I have a lot of clients who are like, I just can't get to sleep.
Yeah.
And they've got the lavender spray. And I know having a routine is a part of it, right? But there is a real connection between the drop in progesterone and lack of sleep. Right?
Totally. Yeah.
So how do we work through, what is that?
So our neurotransmitters are under the control of estrogen and progesterone. Progesterone is that acts on the GABA receptor. That's the feel-good receptor. That's the one that calms us. Estrogen actually interacts with melatonin also. And melatonin changes actually as we are in midlife also. And there's a number of other neurotransmitters that estrogen actually impacts. So, you have direct impact on those neurotransmitters important for sleep. Melatonin, circadian rhythms are also altered during perimenopause. So sleep disruptions are huge during this time period. And a lot of times they respond very well to progesterone, sometimes estrogen, in addition to progesterone. But sleep disruption is another one where you'll hear, earlier rather than later in terms of that menopausal transition. Many times can also be vasomotor symptoms or hot flashes can disrupt your sleep also. And the other thing we have to remember is sleep apnea or snoring. I always ask my patients, do you snore? Because actually women present different with sleep apnea or obstructive sleep disorders than men do. And we're beginning, we don't even know that much about it, but men and women present a little bit differently.
And what's that difference?
So just the symptoms, the symptoms will be a little bit different actually. And so what we classically, consider with obstructive sleep apnea, right, with men is not the same as women. And we need to really further define those basically. But snoring, waking up and not feeling well rested. If you wear an Oura ring like I do, you'll see the sleep disruption on your Oura ring and your oxygen level will go down. And yeah.
Okay, so we've kind of gone through the list of all the ways that menopause can affect women's bodies. And that could, for some people, be very depressing right now.
See, it's not though, because it's time to grab a hold of your health. This is an opportunity.
Right.
Perimenopause is an opportunity, I think.
Okay.
Because it will get you to the gym. It will get you to pay attention to your nutrition. It will get you to pay attention to your stress and lifestyle and your sleep. I didn't really wear an Oura ring until I started really having problems with things, right? So it will get you engaged in your health. Like health and wellness is not a passive endeavor. It's an active endeavor.
Right.
Because if we just let a car sit out in the rain, it'll eventually rust, right? Why let your body sit out in the rain? So I think it's an opportunity to get to the gym, to get into nutrition, to manage your stress, to pay attention to your sleep, and talk to your providers about hormone support also.
And so can you talk to us about, I mean, you've been doing it throughout this whole conversation, but can you talk to us specifically about how HRT and the application of it can reverse some of these things? And what does that look like in the future? What does that give back to your life?
Well, one thing, if you're having, let's just talk about sleep, right? If you have disrupted sleep, right, that sleep is super important, right? If you have disrupted sleep, you're going to have some mood issues, you're going to have energy issues, you're going to have, brain health issues, stressors, inability to deal with stressors. So starting on HRT is going to improve, for many women, will improve their sleep, right? They will get rid of vasomotor symptoms, right? If they're having them. I think for some women too, just feeling that self-confidence again, or knowing that there's something really going on and I can start to reverse this and to feel better with this. So I think globally, in terms of just paying attention to health, but also HRT, the only one thing that it won't do is this weight issue, right? Like, women gain on average between 5 and 7 pounds. They'll increase their visceral fat by something between 16 and 20%. It's like a lot. And it just doesn't reverse that. That's going to be going to the gym, paying attention to nutrition and engaging in really active wellness and, with intention, basically. So, but in terms of some of the other issues, like hormone support will definitely just help you immediately.
But to the point about weight gain, right? So let's just say somebody didn't catch it in perimenopause, right? But then you figure out, okay, this is what I want to explore, and you get, I guess it's estrogen or maybe testosterone, right? That begins to halt it. But you've had that period where you've already been gaining, right? Now, if you halt it, right? And I'm assuming that's possible.
Correct.
So you're able to halt it and then use lifestyle mechanisms to begin to work that off.
Correct.
Right?
Correct.
Okay.
Correct.
Okay.
And yes, and you can do, obviously strength training, aerobic training, stress management, all these lifestyle maneuvers, right, which will be helpful to you. Shifting your macros and your nutrition, right? I was increased protein, decreased carbs, right? But you get all these other benefits from it too. Right. It's not just like, losing that waist or losing that visceral fat. When you lose that visceral fat, better cardiac health, better brain health. I mean, that's why this is an opportunity to grab a hold of your health.
Right. Okay. And then is there any time that HRT is actually dangerous?
If you've had a history of breast cancer that is not early stage and remote, that could be dangerous, right? Okay. I mean, there are definitely some individuals who've had breast cancer that we will cautiously offer hormone support if they're having very symptomatic issues and that type of thing. If you've had a stroke or an MI within the past 12 months, those are situations where, you shouldn't use estrogen. Much more controversial, people will say, if you've had a history of a blood clot or a stroke, never use estrogen, or an MI, never use estrogen. I think that, these are always conversations, but within 12 months, stroke, MI, estrogen-dependent malignancy. Some malignancies you can use estrogen after some endometrial cancers. And then if you've had undiagnosed vaginal bleeding, right? And that would be if we don't know why you're having bleeding. We need to make sure that there's no cancer that we would kick along with using estrogen. And those are the big situations where we say, okay, let's try something else.
Okay. And then the difference between bioidentical hormone treatments and synthetic,
So all of our hormones are made in a laboratory, right? Even the ones that come from a compounding pharmacy are made in a laboratory. And the hormones that we have now that you buy at CVS, Walgreens, wherever, they're body identical, meaning they are the same estradiol that our bodies produce, the same progesterone that our bodies produce. Compounding pharmacies, which make bioidentical hormones, which is a little bit of a marketing term, and I use them in my practice actually because there's some people that may need lower levels or different levels, or may have a peanut allergy. Oral progesterone, if you have a peanut allergy, can be a problem, right? So that you would use a compounded progesterone in that situation. So, but definitely there's some people who may have problems with these somewhat brittle dosing of estrogen. There's like 5 flavors of estrogen, that you can get, or 5 different dosages of estrogen. And maybe you need something different, or maybe you need just a different ratio. And that's where bioidentical hormones can be super helpful. But you have to follow levels because the absorption is not well defined for bioidentical hormones. So you want to make sure that you're getting adequate levels of estrogen and progesterone. And you want to be careful about the uterine lining, making sure you're doing it with somebody who really knows what they're doing.
Okay, so that's important because you said something, I can't remember what you said, but you said it's different from bioidenticals. So there's
bioidentical is like a little bit of a marketing term, right? And then body identical, meaning
so body identical is different from bioidentical.
I think they're kind of the same thing, right? I think they're the same thing. I don't think there's any scientific I don't think that there's any kind of scientific definition, but they are the same that our body's producing. The progesterone that you're using is the same that your progesterone that your body makes.
Okay.
The estradiol is the same that your body makes, basically.
You. So there's no difference.
So there's subtle differences. There may be differences in the carriers, the delivery system, right? Some women can't take oral progesterone, right? Because the metabolites when you take it that are thrown off may be depressive for some women, may make some women a little bit too sleepy. So then we'll start to talk about doing vaginal progesterone or transdermal progesterone, and that's only available in a compounding pharmacy. So this is really nuanced care, right? And again, in our medical system, it's like, okay, we have this medication. It's good for everybody. It's not.
Right.
We have to adjust it. So that's where I think bioidenticals offer a lot of opportunity is if we have to have subtle changes. And then testosterone only comes from a compounding pharmacy. Actually, you can get FDA approved testosterone in men's dosing, and you kind of have to guesstimate. And then it has alcohol in it. The alcohol evaporates, and then the dosing's different. So it's hard.
Right.
And then but you can use a compounding pharmacy or one of those pharmacies that does bioidentical hormones for testosterone.
Wow. Okay.
There's a lot. I'm sorry, I talk really fast too sometimes.
That's why I'm trying to hold on.
I'm really passionate.
And so what does, as we're coming into close, what does HRT treatment actually look like? Because you've talked about creams. I assumed that it was all injections. What does it, somebody signs up for this, what are they to expect?
So the very standard should be transdermal, so across the skin, so that we don't increase the risk of blood clots by taking a pill, right? With the estrogen, so or a patch, basically. Most estrogen comes in the form of a patch. You can do a gel. You can some people like gels, but a patch, something that goes across the skin. So either a patch that you change once or twice a week, and then the gel for the estrogen. An oral pill for progesterone to start out with. If you're having a problem with that, we can always change that into a little bit more of a compounded kind of situation. But a pill that's taken at night, because progesterone makes us sleepy. So I always tell people to take it at night. And then we really haven't even talked about vaginal dryness, actually. But many times the estrogen levels that we get with our estrogen preparations after menopause are not high enough to hit the vagina. So a lot of women will have to use a vaginal suppository of estrogen or a cream also to maintain good vaginal health for not only sex, but also for good urologic health. So that's what it usually looks like starting out with. It's for most people, it's a patch, a pill, and an estrogen cream or a suppository. Maybe if you add on testosterone, right? A lot of testosterone would be usually a cream, maybe a troche that goes underneath the tongue, so a sublingual kind of lozenge. For some people, it can be an injectable also, or a vaginal cream, or vulvar cream. But that's getting into the more, that's like kind of, there's HRT 1.0, which is really a patch and a pill and maybe an estrogen cream. Then 2.0 if you add in testosterone, and then 3.0 if you're not responding well. You got to make sure that we always have to make sure that we're getting the outcome that we desire. So we have to talk to our patients. And I always ask my patients, how are you feeling today? Could you feel better? Right? Because we want to know, are we treating your symptoms? If your mood is off, could you feel better? If your sleep is off, could we help you to sleep a little bit better? And so those are super important conversations to have. And then if we need to adjust and we can't adjust within, our drugstore kind of preparations, then that's when we move into identical preparation. So that would be, I guess, 3.0.
Okay. And is that injections with 3.0?
I'll give that 4.0. So injections, so testosterone can be given by an injection. You can do that. Pellet therapy, some people do pellet therapy. At super high dose, and some women will lose their hair with it, and it's really super physiologic doses. So when we're dosing testosterone, we want to keep it in a physiologic range and not too high, actually. But so some testosterone is given by injections.
And just to be clear, so people understand, with pellet therapy, that's an incision in the skin where they. Could you explain that?
Right. So it's a little pellet that goes in the buttock region, actually tiny. It's like less than an eraser head, basically, and you implant it. And it's good for usually 3 months, but good for 3 to 6 months. And you get these very high levels of testosterone that are then converted down into estrogen. So you just get this testosterone pellet converted into estrogen, but very, very tricky. I mean, more so used in Australia and the United Kingdom. There is data for the safety data for pellet therapy, not well accepted in this country, and can be associated with some real significant side effects, actually, because we're getting testosterone levels in the range of 300, 400, where we really want them, and then they fall down to 150 for a while, but we really want them around like maybe 30, 40. But with testosterone, you're also treating to symptoms, because the other issue with testosterone in women is we don't really know like what is a good range for a woman if she's having symptoms, right? That hasn't been well defined. So we many times will treat to symptoms also with testosterone.
Fantastic. Well, thank you. This has been very in-depth and specific. So I love that. Is there any one last piece of advice, overarching philosophy that you would want women to hear?
I got 3, I think.
Okay.
I think pay attention to your body, listen to your body. If something isn't right, or if you're being treated with HRT and for menopause and something's not right, listen to your body and get a good outcome. That would be number 1. Number 2, perimenopause is an opportunity, and menopause is an opportunity to really gain a hold of your health, right? And to really realize that this is not a passive endeavor, it's an active endeavor. And 3, make sure that you're with a provider that you can speak with. I mean, make sure, kind of my goal and in these next few years is to really get education out to providers also. But get with somebody who will listen to you, who's getting a good outcome for you. And if you're not, get to another provider. And there's certainly list of providers on the Menopause Society is our large society in the United States. There's definitely people who are active in this field, and they're increasing in number, actually. This is there's a lot of momentum behind this movement right now, which is great.
If someone's thinking about taking Ozempic and also doing HRT, what would you say about that combination?
So I like the GLP-1 medications, actually, because for some women, and you're probably aware of this too, that you do all the right things and you still can't lose the weight.
Yep.
And you still can't lose that. And it's not even just weight, it's just the shape shifting. You can't lose that visceral fat, right? And for these individuals, Ozempic and Mounjaro and the GLP-1s have been kind of magic, actually, because for the first time, people are losing weight. And I actually have a patient of mine who'd had like multiple bariatric surgeries and didn't lose weight until Ozempic came out, right? So they're great medications. So I think cautiously used appropriately. I mean, I think if you're overweight or insulin resistant, they're great medications. If you're underweight and you're, they're not so great, right? I think though too, we just have to make sure that we have the appropriate dosing, the appropriate people following individuals who are on GLP-1s, paying attention to things like mood, also super important, these side effects that can occur in terms of any type of gastroparesis or the bowels not contracting normally, or any type of mood disruption, that type of thing. So if done appropriately, I love them. Yeah. I think they've been a big help.
Yeah, I've seen people do very well on them. And again, like you, if it's done with the right medical provider and the right monitoring, I think they're awesome. And I just, people ask whether that combination.
And well, we also have data too now that, so the combination is a great combination, right? Because you're going to get all of the other protective benefits from hormone support, right? Because you're going to get all these other benefits. But also we know that Wegovy, there was data that came out recently that the GLP-1s work better when you're on estrogen, actually.
Oh my gosh.
So it's like even better. Outside of my office, I have an estrogen shower, basically. They come through the door and turn on. But
Wow.
even better effect when estrogen is used. Because the one thing we didn't talk about is estrogen also decreases the risk of diabetes, right? So that's insulin resistance is diabetes. But so the GLP-1s are hitting multiple areas, but also insulin resistance, right? So estrogen naturally lowers insulin resistance and diabetes risk also.
Fantastic. Dr. Poynor, thank you very, very much. This has been awesome. And I think we accomplished our goal. I think we did. So
great.
Thank you very much.
Thanks.
Appreciate it. And we'll talk again soon.
Yeah, thank you for allowing me to speak today and to chat with you. Certainly appreciate it.
Awesome. Thank you.
Great.